next session is a clinico-social case discussion. So as we have been discussing, the overall discussion on equity in healthcare and addressing health disparities can sometimes tend to be a little abstract. So how to bring in equity into the discussion of into discussing the process of taking history, physical examination, making a management plan, and further on preventing further complications. So that is what this session will be focusing on. So this session, we will be asking experienced physicians to discuss their approach to equitable healthcare in relate to concrete cases, which will be presented by Dr. Abisha. The aims of this session is to highlight the social and cultural understandings and patient perspectives of their illness and a clinical approach to cost-effective management and how to apply it at the bedside. I now invite our moderators for this session, Dr. Felix, Jebasingh, Dr. Cijoy, and Dr. Sajitha to come forward, please.
Good morning, everyone. Today, I am presenting a clinico-social case. This is Mrs. Uma Mageshwari. She's a 49-year-old female. She's married, working in a local shop. She's making sweets in a local shop, either a 12-hour shift in the morning or in the night. And she's living at Savalampet in Vellore, which is 20 minutes away from here. She came to us 6 months back with an ulcer over the right foot for 6 months. So the initial healthcare facility that she sought was LCCU, where 6 months ago she had went for an ulcer over the right foot. So this ulcer started as a small nick because she was walking barefoot at her home. She didn't notice until it started discharging pus. And she has actually went to a nearby hospital where they had seen that it's a deep ulcer, did a debridement, but the ulcer had not healed. And she came to CMC. So I would want to throw some light into the basic history, the basic problem, which is diabetes. She was known to have diabetes for 8 years, diagnosed when she was having some excessive tiredness and giddiness. Index GRBS was 350, and she had about 3 to 4 kg of weight loss at the time of diagnosis. She was initially started on OHAs, but was irregular, non-compliant, and then later went on to require insulin for the control of diabetes, but she was very much non-compliant to both OHA and insulin therapy. Regarding the complications, she had burning sensation over the foot for 6 months. She also had frothy urine and blurring of vision in the left eye. There was no history suggestive of macrovascular complications. Regarding her household, she was married. She had 3 children. Her husband was a lorry driver who earns about 25,000 per month. And she has 3 children. First daughter is studying her BCom final year. Second son is a civil engineering student. And third daughter is a BSc nursing. They're all educated, but the lady herself has only completed her 5th standard. And they own a house. They have the land is also theirs. The house is also theirs. It's a pakka house, but it's a single room with a single bathroom and a small kitchen area. This is the family where, as you can see, all the siblings of the patient herself are diabetics, and none of them have had any other complications. All of them were diagnosed after 40 years of age with diabetes. And because she was diagnosed with diabetes and it was uncontrolled for past 2.5 years, they have been taking multiple loans for the treatment. And 6 months back when she was admitted, she also had a NSTEMI. So they have a total debt of about 5.5 lakhs. The family's income is only 25,000. She works, earns occasionally 1,000 rupees per day. A maximum of 10,000 may be added to this family income, but their monthly interest goes to 30,000. So they have only 5,000 left in hand for all the other expenses. And education, as I told, she had completed only her 5th standard, and she's not able to maintain a diet chart and all because she usually consumes whatever is at home, mostly excessive rice-based diet and less of proteins. And regarding the social support, initially, as we saw, there are so many siblings, so much social support. But then as they went into debt gradually, they all stopped talking to them because they were not repaying the amount that they had taken from their relatives. And as I was talking to her, she was telling that for the past 2 months, she was not taking insulin because she did not have money for the same. And that is why she was not seeking healthcare also. But they have a own bike where they can access primary, secondary, and tertiary care facilities, which are all within 20 minutes or 20 minutes away from their home's circumference. She also has the Chief Minister's health insurance scheme, but she tells that it was not applicable when she was admitted in medical care, and she does mostly barefoot walking at home. So regarding her baseline medical history, as I told, she's a diabetic. In May 2023, when she was admitted with us, she came with complaints of vomiting, diagnosed to have NSTEMI. She had LV systolic dysfunction with regional wall motion abnormality, started on antiplatelet therapy statin. She's also a hypothyroid on thyroxine. So she had a IP bill of about 62,000 during the hospital stay with medicines up to 30,000, most of which was taken care of by the hospital. And for transportation, she had used her own vehicle. So I would want to highlight this thing where she had, this is her routine medication list. Excluding the insulin, her cost for a month would come about 2,090 rupees. Now that she has a diabetic foot infection, she has to buy the dressing material, the medications for that, which adds on to the 2,090 rupees. Actrapid also adds to it with the syringes. So the medicines, if we consider the lowermost cost, it will come around 2,500 rupees for a family which has only 5,000 to afford for their monthly expenses. So keeping this in mind, we'll go to the clinical assessment. She was vitally stable. There was pale bilateral pitting pedal edema and ulcer of 4 cross 3 cross 3 centimeter, as I had shown in the previous picture. And there was loss of vibration sense, loss of ankle jerk, all correlating with a diabetic foot. And we can see her HbA1c since 2021 has been 12.9, 10.4, most of the time has been uncontrolled. And she has also developed microalbuminuria. All the complications associated with diabetes have already started.
So at this point, just want to discuss, can you go back to the previous? Yeah, thank you. So by looking at this very clearly, evident that she had a macrovascular disease. But if you look at the temporal pattern, this lady had ulcer prior to her MI. And as well as she was walking barefoot. What make her walk barefoot in spite of having a foot ulcer? It's because they don't have pain. So that is, if I have a pain and I step over a thorn tomorrow and I have a pain, I just come to a surgeon or a medical physician to get a care. So she, in spite of having a foot ulcer in the plantar aspect, patient was not seeking attention for medical care. The simple reason they don't have pain. So it's very important that when it comes to the discussion about diabetic foot ulcer, 99% they won't have any pain, because that's what it's actually a vicious cycle, it's aggravating. So this lady we saw a couple of days back in our outpatient, and she, interestingly, when we asked the history also, she mentions, I don't have any pain. So with our resources, existing resources, how well we can actually probably help in curing the foot ulcer. That's very, very important. Okay, so she'll be showing the foot x-ray, which is done just 48 hours before.
Just, can you go back to her socioeconomic history? No, the later slide. Now, for me, the crux of the situation is, how do we manage a chronic disease in a primary care setup in the context of equitable healthcare? It was clearly mentioned that accessibility was not an issue for this patient. Primary care, secondary care, tertiary care, both private and government health facility was accessible for this patient. Beyond accessibility to healthcare system, what are the patient-related factors? That is kind of not very clear, because one side, all the 3 children are graduates, which is good, which we would assume would help her in understanding that a chronic disease will need lifelong compliance, follow-up, and regular checkup. However, that did not translate into her practice. How well could we have improved that if we see similar patients in in a primary care level, either from a poor socioeconomic status or from a better socioeconomic status. So could this have been prevented with a better follow-up? The non-compliance was highlighted. Non-compliance, was it just due to patient's poor understanding, or patient did not prioritize this as the top of her list of things to do? Those are the things which, as primary care physicians, whoever is managing similar chronic diseases, have to evaluate. How better we can get this message across to patients that this is this is one of the most prioritized things to be for you, so that you don't end up in more expenses, medical related expenses.
So Ken, how many of you say that if you see a patient of this in your outpatient who come with myocardial infarction and look at the feet of a patient with diabetes? How many of you look at the feet of a patient if they come with a myocardial infarction or a stroke? See, if you go back to your patient who has a diabetes, come with a myocardial infarction or a stroke or maybe a road traffic accident, which is probably look at in a different way, you will find 90% will have some callosity, fissures, corns, etc., which is actually a pre-ulcerative state. So this coming to this patient, if you look at this patient has probably had a myocardial infarction. We are not focused on the foot. It's actually aggravated into a foot ulcer of 4 centimeters. It did not happen overnight. And moreover, if a patient with foot ulcer come to you, how many of you do an X-ray for every patient with foot ulcer? X-ray is not a very difficult investigation, at least in many parts of India. I do agree there are certain areas where still we have difficulty in doing an X-ray. A simple anteroposterior view of the foot X-ray, which was done just a few days back. Abisha, can you please explain that?
There is a breach in the cortex in the base of the right third metatarsal bone. This is suggesting an osteomyelitis that has been happening.
So one of the important feature in diabetic foot ulcer is that your bone to probe test will be negative in most of the time. It's highly specific, but it's not very sensitive enough to pick it up and say if the bone to probe is positive, that means it's there. But this patient has bone to probe was absolutely negative. It was just 3 millimeter depth, but no bone was visibilized. There were fascia is intact. But that is how the diabetes behaves, especially in foot with osteomyelitis. So that is the reason for her delay in wound healing. And moreover, the norms of all the osteomyelitis has to go for surgery is not the norms here anymore. You can treat with antibiotics unless if the patient has a peripheral arterial disease or maybe a gangrene which is evolving or life-saving. You no need to worry about it. You just give it antibiotics for 6 to 12 weeks and get away with that. And it gets sealed completely and probably a complete offloading or a partial offloading with appropriate footwear. So it's a simple X-ray, which is actually is very, very important for any patient with diabetic foot ulcer if it is more than 3 weeks of duration, whatever the size is. Yeah, please continue.
So our final diagnosis was a patient with type 2 diabetes with diabetic neuropathy who has developed osteomyelitis of the base of third metatarsal bone with a diabetic nephropathy, a coronary artery disease, and a hypothyroidism. So what were the social determinants to be considered in her? So when she had come, actually we had asked her to get a MCR footwear because of the neuropathy. But this costed around 2,500 rupees by then. She had not brought it. Instead, she went to a local market, bought this Ortho Plus slippers, which is 150 rupees. And this is what she's using. And she was also advised insulin, but was not able to afford. So in this case, one thing that would have helped her is early diagnosis of an osteomyelitis, which would have better healing results. So when do we suspect an osteomyelitis? It's when an ulcer is more than 6 weeks, more than 2 centimeter, depth more than 3 mm, or a sausage 2, ESR CRP elevation, or if there is exposed bone or history of recurrent ulcerations. So we had actually started medical therapy recently for this patient. Antibiotic therapy without surgery is as effective. And when do we go for a medical therapy? It's when there is 4-foot osteomyelitis, when there is no peripheral artery disease, and there is no exposed bone. So I would want to highlight few things. Diabetic foot osteomyelitis, as we saw in this patient, for 6 months can be asymptomatic. A simple X-ray can actually help in picking up this patient early. And ultrasound can also be used as a good modality. And long-term antibiotic therapy, which might not be a big cost, will be also helpful. If we require amputation, we can proceed with that. And offloading with footwear is the most important measure that we have to use, which was actually missed in this patient because of her financial constraints. So our treatment plan was optimization of diabetes, antibiotic therapy, and modified footwear with offloading. So this was the footwear that we gave. It was an anterior rocker, which actually offloads the foot ulcer that the patient has, which is in the anterior aspect. And the other would be, this anterior rocker has a pivot of about 65%, which can actually help in offloading the ulcer. This is another modified footwear, an ortho wedge, which can also help in offloading anterior, that's the forefoot ulcers.
Abisha, I'll just explain the rocker. See, the rocker being used for patient with forefoot arcement is nothing new. It is just a reinvention of whatever existing. We are sitting in a building called Paul Brand building, Paul Brand block. The Paul Brand has actually shown this to be effective almost for 5-6 decades back itself, that when he was here, he was using it for wisely for Hansen's disease. Hansen's disease is, I used to think that diabetic foot is nothing but a modern day Hansen's disease. All the deformities, all the osteomyelitis change, Charcot, everything is similar. Only difference is that the Hansen's, it's not a progressive disease. You treat with anti-leprous medic drugs, it actually stays there and the deformity stays there. But in diabetes, it's progressive. You treat whatever anti-diabetic medication, insulin, it keeps on continue to worsen till they get some burnt out disease like Charcot, or maybe end-stage deformities which we cannot reverse. So that is a basic difference. That is why the footwear in terms of diabetes is actually a progressive prescription you have to give. You see, every time you end up changing the footwear every visit. And especially if you look at the rocker, it's all our footwears which you are using. If you're buying from a traditional shop, you all will have a rocker. You look at your footwear, especially shoes, you will have 2 to 3 degree rocker. All your footwears in the front part will be elevated. It's nothing but a rocker. And what we are doing right here is exaggerating the rocker to 10 to 15 degree and actually making sure that when they walk, the toe phase is off, so that there is no connection between the footwear and the ground, so that the patient gets offloaded. So what is using is nothing new. It's an exaggerated rocker, which you and me are using enough, especially the shoes. We are using in the Western countries, the shoes as all the rockers. In Indian subcontinent also, we are all the shoes as rocker, which is around 3 to 4 degrees. We are exaggerate to around 10 to 15 degree up to that, depending upon patient to patient. And that's how it is. So wedge is nothing but an exaggerated way where it is the pivot, which is nothing but the elevation happens at 55 degree. Here in our shoes, it happens at 65 degree. There it happens as well. If you look at the cost, then everybody look at the cost. Yes, but if you look at the cost, nowadays, even all this footwears are available online marketing. One, and it's much cheaper than what used to be. If you're making in-house, only the footwear cost goes high because of the manual cost, which is accounted to that. But if it's machine made, it's much equal to your whatever footwear we are buying for in the shops. And I will ask Dr. Cijoy to talk about the foot ulcer and the renal disease which is behind that.
Yeah, thank you for bringing that, the other aspects, important aspects of this. One thing to add on to that is some of those interventions that we talk about in any of these diseases. Yesterday, we were looking at tuberculosis and other diseases also. There are certain interventions which, even though expensive, are cost effective in the long run. Another example would be using meter dose inhalers in asthma. Of course, initially, the capital expense, when you look at it, may be looking high, but the total savings for the patient is likely to be more if you are well controlled on asthma. Similarly, in this patient's case also, the amount of financial loss that could happen with poor glycemic control and all the problems that come along with that, including the micro and macrovascular complications and the diabetic foot. Another example, Dr. Felix mentioned now about the footwear. Expensive, but there are always options which we can use to minimize the expense or make our own modifications according to each situation. We may have to contextualize these interventions. But one principle, as a principle, we have to remember is any of those diseases, non-communicable diseases as well as communicable diseases, there are certain interventions which are on the expensive side, but are worth the cost that we are paying for it. The cost effectiveness has to be kept in mind always, especially in chronic diseases. That is one important aspect. The other aspect you were mentioning about the renal.
So when we talk about diabetic foot ulcer, one of the biggest risk factor for chronic disease, it has been not been highlighted in many textbooks, is even in the literature. If you look at the chronic kidney disease and foot ulcer, if the patient has persistent foot ulcer, which is nothing but a local infection, which is producing the infection continuously, it is detrimental to the renal functions. So it is even in Indian studies, it's clearly mentioned that when they have a foot ulcer and without foot ulcer, the decline in the eGFR, it's much higher in patients with foot ulcer than without foot ulcer. One. Second thing is, if they have a foot ulcer and they have infection, obviously we all know that sepsis worsen the renal functions. So when there is worsening of renal functions, if the patient has foot ulcer, they don't come back to the baseline. They have a higher renal, higher creatinine levels when they go back to their normal. That means the patient without foot ulcer, creatinine, let's say, goes to 1.1. With foot ulcer, it go to 1.3. For 0.2 milligram, we feel that probably, okay, it's fine, but it convert to eGFR, age, weight, it is actually detrimental. So that is how the decline in the GFR is very, very important, especially when, because it's a long-term effect which we are not focusing. It's very, very important because that adds to the cost, which is a chronic kidney disease and its sequelae.
Sure, you had put that picture of how diabetic foot and its related mortality is. Do you have that with you? Yeah, it comes later. Okay, then we'll go that later, no problem. Another aspect to remember in this context is to think that type 2 diabetes or even other diabetes also, it is practically two different diseases for the resource rich and the resource poor. So they are two different diseases. Do you think, how would it be different in terms of, say, for example, pathogenesis itself? We won't go into that in this discussion, but then at least can you think of how it would be different in terms of diagnosis and subsequent follow-up?
So in a resource-rich patient, they have a more regular follow-up. They have the financial things, even if they develop complications. They have the access to healthcare in the form of the financial things. In this patient, actually, she belongs to a lower middle class, and all her people, like all her children, are graduates. A fairly educated scenario, but still her understanding of the disease was less, which might not be the case, is what I feel, in a resource-rich setting. We may be able to communicate, like we may be able to make them understand the disease better because they come for a regular follow-up. But in this patient, because follow-up was a difficulty, we were not able to communicate how the care would differ when she comes for a follow-up or not, and what is her disease. That was the primary thing, I would say. Second thing is, all these devices that we are talking about might be accessible more for resource-rich settings than a resource-limited setting. We know that we were discussing that there were cheaper facilities also available, which might be known to the resource-rich people. But for these people who are resource limited, I don't think they will know that there are other options available also. That was the case in this lady.
Yeah. Even the clinical presentation, could that be different?
Yes, sir. So she had come with 6 months now and not taken care of. But in a resource-rich setting, as we all know, they would like essentially come at the earlier stages itself. Even the diagnosis of that, we see multiple patients coming for routine checkup, diagnosed with new onset diabetes. But we can't see our people coming like this. coming like that to us. It is always with some complication that we like pick up the diabetes in the recent times. Now that there are multiple government schemes, they go there, like screen the community, might be less, but I feel more patients we see are or with complications onset in the resource poor settings.
Yeah. So even when you come to management also, you can think of it as two different diseases. I essentially look at it this way for any diabetic patient, irrespective of where I see them, maybe in the ICU, in the ward, OPD, or even on a train journey, or even at home. You meet somebody, they always ask for opinion or advice on diabetes. Every doctor faces that. So I essentially tell them about the management and under 3 C's. Is the control adequate? That this can be extrapolated into other lifestyle diseases as well. Is the first C, is the control okay? Second, have I looked for, prevented, and managed complications? The second C, have I prevented, diagnosed, and managed comorbidities? What would be the comorbidities commonly that you see along with that? Hypertension, dyslipidemia, in obesity, even in the lower socioeconomic strata, especially from what we have seen in certain schools and all, even in the lower socioeconomic strata, high prevalence of obesity now we are seeing. And that also has brought down the age of onset of type 2 diabetes in this thing. There are probably other aspects of policy and other things also. How would the poor actually, how their diet and other things would contribute to that? Is there anything related to that? Previously, maybe 30, 40 years back, people used to say having diabetes is a status symbol because you are affluent. That is what it meant. Now it's no more that. If you look at the Western data, you will find that more than 50% of the Black American adults are obese. It would be very different in the white population. The underserved people tend to be more obese there for obvious reasons. Very similar reasons we have here. Can you imagine what it could be? Yes. Tamil Nadu is a very well-developed and fairly well-run state. In spite of that, why would there be so much of childhood and adolescent obesity and even leading to this? Lifestyle issues, and even the government's policies of subsidies are predominantly subsidizing through public distribution. What is being subsidized? Rice. Predominantly carb. So all these contribute. It is not just one issue. It's probably too many issues, but I'm just thinking, I look at people at wherever I'm seeing them, even at a family function, I'll look at these 3 C's. The control, is it okay? Then you can, in your mind, you can divide according to the resources. Anything is possible, very limited possibilities are there. You look at control differently. You would have looked at the newer analogs or insulin when somebody's HbA1c is 12 or something. Naturally, you would have looked at that. But in another person, you would have looked at the insulins that are available in the government hospital for free of cost. Many of our patients take the insulin from the government hospital, come to us for dose adjustments, and we adjust, and then they go home. Things like that. You can look at control. Resources are okay, resources are limited. Complications, again, resources are okay, resources are limited. Good that you are mentioning about X-ray. You may be mentioning a little more about how a simple thing like X-ray can make a big difference in a patient. Similarly, comorbidities also. To look at how resources are all okay, you can look at a different way. When resource limited, you can look at a different way. There was a big list of medications also. Some of them we cannot really change. What do you think there are any ways of reducing the cost in those medications?
You can get generic.
Yeah, one possibility is generic drugs, provided you are confident about the quality of those. That is one.
Government is actually providing free insulins, which
yes, so people can get free insulins from government. Any other? There are certain drugs which are very essential drugs are price controlled by the government. For example, if you give aspirin and clopidogrel separately, it will be extremely expensive. We generally do not advise combinations. But when a drug which is essential, government regulated price is combined with another drug, the price just crashes down like that. A combination of clopidogrel with aspirin cannot go beyond that point because government has already regulated the price of this thing. So such gimmicks you can do even in your prescription, provided this aspect is in our minds. Okay, this patient is like that. Any other ways, institutions and hospitals, probably many of you are from hospital backgrounds. Hospitals can work on this. They could look at how you can negotiate, as yesterday we heard, the doctor is also an advocate for the patient. You can negotiate with the pharma companies. Avoid all the freebies. Take out everything, every kickback. Put that into the medicine. You don't give anything to any of our doctors, but bring down the price of the drug. We can negotiate. We have quite a lot of negotiating power when it comes to these things as doctors. So these are all ways at each of these levels. One is to sensitize ourselves to know that diabetes is a different disease for the rich and the poor at pathogenesis, clinical features, diagnosis, and even management. So that is our own sensitization that happens. Then at each level, how can we intervene differently? This is also quite important, I think. Please.
Abisha, I just want to add, again, Dr. Cijoy touched about the different perspectives between the low resource and the high resource. So in a low resource setting, how do you think a healthcare system can respond? She does not want to come to the hospital for many reasons. Is there an alternative way the healthcare system can reach the patient?
Outreach clinics.
Outreach clinics are one way. Should it be doctors? Should it be the clinical professionals? Or could it be somebody else who can be more there in the community and who can probably help them understand the disease as well as follow them up when they are not able to come at the right time? That is one thing which is researched and proved upon in many communities, that non-clinical professionals or non-clinical trained people in the community can improve and does improve the outcome of chronic diseases. That is something which people working in secondary care hospital are already part of similar systems or can explore such systems. Do we really need a clinician to do this entire spectrum of diabetes care? Beyond because diabetes has so much of non-clinical issues and eventual outcomes on their individual lives, can that be delegated to non-clinical professionals who can be a community health worker or who can be a community health volunteer, who can improve the understanding as well as ensure better follow-up? Because the whole idea when it comes to managing diabetes in population from low resources, can we prevent hospitalization? How can we help them live with this diabetes, which is a chronic disease? It is not a one-time hospitalization issue. So how can we improve that? That's a question which, as clinicians, we will have to decide.
Yep.
So the other option for offloading, I would want to highlight, it's a very cheap option where we can just use a metatarsal bar, which is available in the outside like shops, which we can use actually as a small wedge-like thing in the middle of the footwear and offload the foot. And for this patient, follow-up and monitoring, she had a very poor OPD follow-up. She had always come for admissions, getting discharged and went. The only thing that she told me was she would lose her wage for one day if she had to come to hospital. That one day would give her something for her livelihood. So just a few things. As Sir had already mentioned, pain is a gift that God has given us. Only because she didn't have pain, she had not come to the hospital at the earliest. So we should think about it. And various pre-ulcer stages I would want to highlight.
Yeah, so it's very important to have a primary prevention here, because in a OPD with patient with diabetes, please look at the foot of a patient, even if the patient has come for the first time diagnosed diabetes, because it's very, very important. So do you think that this has to be treated? What is this? What condition is it? It's a fissure, right? But when because the fissure don't happen at this toe frequently. So it's actually an osteomyelitis. So if you don't look at this and don't treat it adequately, she's going to lose a greater toe and she'll end up having a much more financial loss and as well as a socioeconomic problem.
These are callosis which patients develop because of cross-sitting. They sit down, some BD workers and all, they sit cross-legged and do all these stuff. And they develop all these callosis which develops into ulcers and deformities, which actually, when we prevent at the earlier stage, the cost might be lesser. When they go into the stage of amputation, the cost combined would be higher than the cost that they put for a footwear. This is the barefoot walking, which is causing a ulcer at the pressure points, which most of our patients do even with their ulcers in situ.
Barefoot walking in the temple. Just ask them to wear a sock and go into the temple, because our religious places is sacramental. So we do that. But simple education, don't walk in the religious places. Use a simple sock.
This is another toe ring that was causing a ulcer and an osteomyelitis.
How many of you see what you see in this picture? What do you see in this picture? Someone can say quickly. I'm sure everybody is looking at the right foot. What about the left foot, which has a callosity and a fissure? So the patient already had an amputation in the right foot, but there is an impending storm waiting to happen in the opposite foot. If we don't take care of that, we are going to get amputation at least 5 to 10 times in the next 5 years' time. Other important modalities, we are talking about X-ray, because what we are doing is actually we are doing in CMC in a tertiary care. Especially in diabetic foot, there is no difference in treatment for a poor or a rich. It's almost same in CMC fellow. So one is X-ray, second is ultrasound. If you look at the guideline, they say that if you suspect osteomyelitis, you do a MRI. But in CMC, we do a simple local ultrasound, and the local ultrasound picks up the osteomyelitis much more than anything else. Simple, just 2 minutes without no exposure to radiation. Just do an ultrasound, see the irregularity and treat the osteomyelitis.
This is just to sum up whatever I've talked so far. As we can see, we put the wounds, amputations, the mortality associated with the cancers versus diabetic foot infections. As you see, the neuropathic diabetic foot infection, amputation, ischemic diabetic foot ulcers, PAODs. When you combine all these things together, the mortality is even higher when compared to all the cancers combined. So it's actually a very big problem that we are facing. And one thing that I learned from this lady is a simple foot examination should have been done, and a simple X-ray would have helped her prevent so many complications as she went into now has developed a osteomyelitis as well. Second thing, third thing is that patient education. We should have educated much more in the earlier stage itself, telling it's a chronic disease. There are expenses associated with it, but the expenses that they spend might minimize the long-term amputation related or any other complication related expenses in the long run.
Anyone? Anybody from the audience, any of the seniors who are here would like to add on or? Okay. Thank you, Abisha, for that presentation. Thank you. Thank you.
Thank you everyone for that excellent discussion.